How to create an evidence-informed practice. Your evidence. Evidence-informed knowledge and measurement must include the practice environment of each practitioner because patient outcomes are somewhat unique to that context. Measurement in practice is not confined by the restraints of RCTs and other study designs. It's allowable and preferable to use a less scientifically restrictive approach because with no intention of extrapolation to other practices, it reflects the context of the same environment where future patients will be managed and where data is relevant. You'll likely say, I already know who improves and who doesn't. Well, no, you don't, at least not entirely. Recall bias is often focused on successes, so you remember those events that support your belief in the value of what you do. Not in and of itself a bad thing, but not unbiased. You may not recognize how good you are at patient presentations that you assume will respond based on your past experience. You may not count those patients who received benefit through referral. And you may tend to selectively forget those who don't improve and attribute that result to the patient, lack of compliance, attitude, etc., or not count them as a non-responder because they simply never returned to convey that information. Science is not the enemy here, but scientific studies can't tell you how patients will respond to you specifically because of these unique elements: your office space, your procedures, your demeanor, your patient's beliefs and attitudes, and your techniques and experience. All of these factors are unwanted variables in most studies and are either eliminated or at best controlled for in most study designs. So how do we blend both sources of information into evidence-informed practice, leading eventually to best practices? Well, we can do just that. Blend in, integrate in the scientific approach to how we observe and monitor our patients. Without being a scientist, we can act and behave scientifically. But there is mistrust here between scientists and clinicians. Here are the pluses and minuses and biases of what appears to be a dichotomy: the scientist and the clinician. Here is the scientist's perspective. Attempt to systematically eliminate any bias in drawing conclusions and determine how much chance may play a part in the results. Address as many variations as possible through research design, but make patient groups homogeneous in comparison, meaning that comparing groups requires that both groups are similar in demographics and other factors regarding their condition, pain levels, acuteness, etc. This is because the scientific perspective is that clinical expertise is often the product of the classic representation of the biased environment. Here are the major concerns about human observations. Things may not be what they appear to be, so that attempts at finding out the truth must avoid the two natural deceivers: bias and chance. There are many forms of bias, but the most common is having an expectation based on prior experience or trying to get a specific result. Bias in the reader is believing a positive report because you want to find support for your beliefs, and the opposite: discount the results of studies that don't support your belief system. When bias enters into a study, it's called an error. Bias can enter into a study at all levels, including the participants, examiners, staff, and reviewers. Chance. The probability that chance is the reason for an occurrence is more likely if seen rarely or by a single individual, and less likely if occurring frequently and observed by many. Studies can measure this occurrence and calculate the chance that chance is the potential reason for a result. The more individuals in a study, and the more studies that support the same findings, the less likely that chance is the cause of the results. Chance occurrence is reflected in numbers such as p-values and confidence intervals. Believe it or not, you can calculate these using Excel or other numerical spreadsheets without doing the math. So the point here is that we as humans believe that if chance is the cause of a result, it's not frequent. But actually, we don't understand how strong a feature it can be in certain scenarios. And remember that recall bias is an issue for our determination of how frequently something occurs. Finally, the scientific concern about what appears to be a successful outcome is placebo. We're less concerned with placebo in our practices because placebo still results in a successful outcome. Scientifically, we want to avoid placebo to determine the truth about an intervention's direct cause of an effect. But in practice, this becomes less relevant. The only ethical dilemma would be if a patient avoids a known intervention that is safer or cheaper. The clinician's perspective is to do the best you can for the patient, even if it does not match the literature. Each patient is unique, and no amount of literature support for a given opinion can cover all possible scenarios. The major concern by clinicians, and an excuse why studies are ignored if they don't represent what the clinician wants to hear, is that the scientific perspective is the epitome of disconnect to the individual patient. But is a desert island approach defensible? Well, only when you have no choice should you use the best available tool to accomplish the task based on your experience. When you have a choice, is it ethical to create a scenario where you limit your experience and knowledge, and therefore your choices, and become the person on the desert island you created? Common questions and concerns about scientific validation of what you do include, if I question everything, what can I trust? If I question everything, how can I have confidence in what I do? If I don't try to stay up to date with techniques that promise high-tech advances, how can I provide the best care for my patients? The solution is through the understanding that evidence-informed practice allows and demands that you generate some of the evidence upon which you make decisions. You become the clinician scientist. The clinician scientist mentality is simply a change in focus. It requires that you apply scientific principles to observations in your practice. Apply literature recommendations when possible, even if it is not your customary management approach to test out the literature. Participate in research and research design, especially your research of your own practice. As a point of departure, let me review for you a small project conducted by a group of chiropractors in the Midwest. The intention of the Best Practices Academy was to teach doctors how to measure in their own practices and demonstrate how by sharing this information anonymously, they can find opportunities for improvement. To gather information that is relevant, it has to be consistent and meaningful. How chiropractors and others code patients is inconsistent and to some degree random. So how can you know how well you do with a given patient presentation compared to others, or even yourself, if the same patient presentation is coded differently? Remember that ICD codes are not CPT codes and have no operational definition. Participants were given a series of different case vignettes and asked to code them as if they were current patients in their practices. Participants submitted their primary and secondary ICD code choices for each. All data was combined and analyzed to determine the degree of variation among doctors who used different codes for the same patient presentation. As illustrated in the following case vignettes, if a determination of the types of cases seen by chiropractors and their success in managing these cases was attempted, no conclusions could be drawn simply because for any given code, there is no agreement. Some problems are due to habit, some based on philosophical grounds, and some on perceived payment preferences or perceived payment requirements, such as Medicare. The following slides present the case vignettes used. Although there is no particular correct code, the result illustrates the problem with variation. What becomes apparent is that there is a large variation among the practitioners' coding approaches. For some, the subluxation code was always used as the primary code, regardless of patient presentation. We use cervical spine pain cases. The approach to coding used by most doctors does not allow the distinction between those patients with cervical radiculopathy versus those with referred pain into the arm. The approach was consistent on the whiplash cases we'll see. However, it was coded for mechanism, not patient presentation. So here briefly are the cases. So here's case number 1, a 35-year-old male patient with left neck and arm pain rated as a 6 out of 10. The pain radiates down the outside of the arm and continues across the hand in a diffuse pattern. There's no trauma or past trauma. There's tenderness at the C5-C6 area with segmental restriction at that level, no positive orthos and neuros, and some end-range pain. No radiographs are ordered. Look at the variation here. The doctors generally coded this as subluxation, but there were many other primary codes chosen. The doctors recognize that this is something that is likely facet referral and will respond to adjusting. But how do you differentiate this as a code from a facet-related problem that does not refer or radiate? Here's case number 2, a 60-year-old patient who presents with a complaint of moderate neck and arm pain. There's no history of trauma. The pain radiates down the arm to the middle finger. The pain is increased in the arm with cervical compression testing. There's hyperesthesia over the same area of pain, but in a patchy distribution. The triceps DTR is a 1. Radiographs are taken, and there is evidence of spur formation and decreased disc space at the C6, C7 level. No MRIs are ordered. Your treatment plan includes manipulation. With case number 3, we have the same patient as number 2. However, MRI is ordered and indicates disc herniation at the C6, C7 level with nerve root involvement at that level. Again, much variation. Even though this is clearly a radicular problem given the findings, there are many different codes used by doctors to categorize it. Probably even the same doctor uses different codes based on minor variations on this presentation in their practice. Case number 4 is a 30-year-old patient who presents with no pain but interested in chiropractic care. There is no trauma reported. There is tenderness to palpation on the right side of the neck at around C4 through C6. There's restricted accessory motion at C5. Neurologic testing is normal. Now we see some consistency with this asymptomatic patient with restricted segmental motion, most called a subluxation. But remember, many doctors use this same code for patients with severe pain radiating into the arm. Do both patient types respond as quickly or as well? Case number 5 is a 35-year-old patient who was involved in a car accident. There was a whiplash injury, and he's complaining of neck and left arm pain and some dizziness. The arm pain is diffuse across the back side of the arm to the hand where it spreads across the back of the hand. The arm pain is not made worse or relieved with any ortho testing. Neurological testing is also normal. Neck pain is worse with stretch into flexion. Active flexion and extension causes some neck pain. Cervical oblique radiographs demonstrate mild foraminal encroachment at the C5-C6 level on the left. No other abnormal radiographic findings are found. Again, we have consistency around the mechanism of the accident, but note that unlike the other coding for patient presentation of complaints, this does not include any criteria for patient presentation by symptom or sign. In other words, radiation or no radiation. That makes this inconsistent with the previous approach that doctors used. Case number 6 is a 28-year-old female who presents with a complaint of severe neck pain rated as a 9 out of 10. She said she awoke with the pain and cannot move her neck more than a few degrees in any direction without sharp, severe pain. She has no fever, and she has active range of motion that is severely restricted. However, she has about 20 to 30 degrees more movement available when tested passively. There are no positives on Kernig's and Brzezinski's. Cervical compression is painful in all positions at the C5 and C2 areas only. There are no neurological signs or symptoms, and there is no associated arm pain. There is segmental restriction noted at C2 and C5 on the right side. This acute presentation is seen commonly, but there is no agreement as to what to call it, let alone code it, so you again see quite a bit of variation here. So what these coding vignettes illustrate is the lack of consistency in calling the same presentation the same thing. What is needed for true comparisons is consistent naming of a presentation regardless of whether ICD codes are used. If the pain structure is used as the approach to coding for some patients, but the mechanism is used for others, you immediately establish inconsistency. Remember that for study purposes, we're not concerned with insurance companies or others and their idiosyncratic requirements. We simply want to call all similar presentations the same thing so we can compare. Our solution to the problem in our small project? It was through consensus. We operationally defined which codes represented which patient presentation and asked participants to use these codes in providing data to our project. In this way, we would know that a given patient walking into any of the doctor's offices would be coded the same, and therefore data regarding outcomes would be comparable. And we limited this project to low back pain only. It's important to create categories of patient presentation, and there are many angles to this approach. it doesn't matter so much which angle you take. It matters most that it is consistent for you so that apples are apples and not oranges. In our study, for example, we agreed on the following. Subluxation or segmental dysfunction would be used only as a secondary code unless the patient was asymptomatic and had indications of vertebral involvement. Primary coding would not identify mechanism of injury, but would attempt to indicate the source of pain, sometimes generally, and whether there was nerve root involvement or not. So how did we code the data? For our classification, we agreed to the following sequence and discrimination. Is there radiation of pain? If yes, are there positive orthopedic or neurologic findings supporting a specific disc or nerve root level? If no, don't call it a radiculopathy. If yes, is there special imaging confirmation? If yes, use one code. If there is not special imaging evidence, code it differently. Next, if there was no radiation, was there recent trauma? If not, is this a chronic condition with no recent trauma? Each of these distinct entities was coded so that we could represent each in our data. Here's a list of our consensus codes. Here's the composite table for different patient presentations in our group of doctors' practices. Note that they are not equal in any way. Individual doctors saw different percentages of patient types compared to each other. We see the group averaged on the left and two individual doctors on the right. So what else did we measure? We measured changes in visual analog pain scale scores, oswestry scores, and the percentage change after 2 and 4 weeks for each ICD code. We measured the average number of treatments per ICD code. We measured the average time for treatment of each ICD code. Let's look at these briefly to get a global view of results. Here are the total number of treatments. Treatment visits averaged around 6, and the length of treatment averaged around 3 weeks. For individual doctor performance based on ICD code, we coded each doctor with a letter designation. Doctors knew which letter they were and could compare themselves to the group. They could also see how they compared to the best of the group. Doctors who perform better with a specific patient type could be interviewed and observed to determine what is different in their approach. In this group of chiropractors are clearly beneficial in the first 2 weeks of care for most patients with low back pain regardless of presentation. Chiropractic doctors see different percentages of presentations for low back pain. Some doctors are better on average than others in managing some presentations compared to their peers. So you may ask, what's in it for me? If I measure in my practice, it will just be an added burden with no apparent benefit. You can map out your patients by presentation and determine your effectiveness with each type. Your successes are marketable. Your weaknesses are remediable when you're part of a group that compares. So how do you get started? Choose a region, design operational definitions for different presentations, whether you use ICD codes or some other identifiers, just so you are consistently calling similar patients the same thing. Next, decide how you will record the information, which will include some intake information and ongoing information about visual analog scales and outcome measures. For patients, inform them as part of HIPAA that you monitor them as part of how you manage and improve your practice. Unless you intend to publish results, you don't need approval from an internal review board, but if you do want to publish, contact your closest chiropractic college for information about how to submit a proposal for this requisite for published research. Next, assure a process that requires patients to complete the outcome measures at specific points. If you use a paper method, you'll need data entry by someone in your staff. If not, consider using an Excel approach. Let's look at how this can be set up. So here's an example of an Excel spreadsheet that you can use in practice to capture data on your patients. We're using many of the same parameters we used in the project just presented. You don't have to use ICD codes, but use some kind of patient presentation discriminator. Notice that we put the parameters across the top in columns, and that's on purpose so that in the future we can capture these and create graphs. If we look across the top, we see that in addition to diagnosis, we're capturing visual analog scale measurements, oswestry changes, total number of visits, length of care. We even capture the type of treatment used on each patient, and the legend for that is seen here at the bottom. So how do you make this information usable? Well, one way is to make a copy of this particular sheet and then statistically change it so that you can sort by ICD code or any other factor that you choose to evaluate. How you do that is to right-click on the sheet that's open. Left-click on Move or Copy, check Create a Copy, and click OK. Now you have a copy of the same sheet you were looking at previously, but now you can manipulate this to create what you want. We're going to make the sheet a little bit more visible, so we'll make it smaller. And now what we're going to do is outline all of the information that we want to sort. And now what we'll do is we will click on Data. We'll click on Sort. On the drop-down menu, we'll pick Diagnosis. Click OK, and now the data has been sorted by the ICD code. We'll make it larger so you can see the sorting. Here you see all the 722.1s, followed by 724.3, etc. Now what we can do is separate these by creating rows. Here we're going to click on the row that has the first 724.3, right-click, and insert. Do that once again just to create a little bit of space. And now what we can do is take any of these parameters that have numerical value and we can average them out. So we'll make that visible. We're now going to take all of the numerical values, outline them, and what we'll do now is go back to Home, and you see this feature here, which is an auto feature. We click on that, and we see that there is an element here called Average. We click on this, and now we see the average of those particular 5 patients that had that same ICD code. Another feature that we can use is we'll take some of this information and see what it looks like in a graphical format. Let's take the visual analog scale for, let's say, the first measure. If I outline that information, all I have to do is click F11 and a graph automatically generated. Now if I want to change the look of that, we can go to the top and click Change Chart Type. Here we'll check on columns and click OK, and we can see we get a visually more appealing graph. It also creates a separate page for that under Chart, so we can see here Chart 1. So let's look at some other ways of viewing the data. I'm going to freeze the frame next to the 722.1 ICD code. Now we can see all the patients with that code and their VAS and oswestry progression from the first entry point, then at 2 weeks and 4 weeks. An interesting pattern may occur. This is fictitious data, but it does illustrate how you can compare the results among patients. Here we can see with just these 5 cases that the first case and the 5th case did not seem to improve as much as the middle 3 cases. We can look over to see what techniques we used on those cases and what ancillary techniques we used. For example, in the 3 cases that did improve, D represents decompression. So perhaps this had some effect on the improvement in those cases. It's at least an interesting point to compare. Another thing that we can do is we can look at the comparison in the VAS from the 1st, 2nd, and 4th week compared by ICD code. I've taken these and averaged them for each ICD code and placed them in a 1st, 2nd, and 4th week column next to the ICD code. Now, when we highlight these and then we go to Insert, we can click on Column and click on the Comparison cylinder. This now produces a relatively interesting graphical representation of the difference in improvement for each of the ICD codes. The back row of columns illustrates their entry point and progresses forward to the 4th week. We can see that for some ICD codes, the patients improve more than for other ICD codes. This is information that for large groups of patients may be lost in your memory, but illustrated very graphically here in the chart. Hopefully, this brief exposure to how data can be acquired and compared has captured your interest. With some planning, you can weave into your office procedures methods to capture data for meaningful use. By identifying the percentage of patients that represent a specific patient type, categorizing them either with operationally defined ICD codes or other classification schemes, and comparing effectiveness, you'll have a global view of your practice. Knowing how well you do with specific patient types and comparing the management methods used for each patient type, you can develop ways to improve your management approaches. Graphical representation can drive home the point about what your practice represents and the comparative results you achieve. These are powerful communicators of your successes.